good morning and good afternoon. Thank you so much for joining this special session on COVID-19. My name is Mr. Ndlovu Nobile. I am the ASLM CEO. So this session is going to be 1 hour, 15 minutes long. It's a panel discussion. And please, during the course of this session, if you have got any questions and any comments, do not hesitate to put them in our chat box as the session progresses. And also there is simultaneous English to French language interpretation that is available. Please select your choice on your screen. Just allow me to put up my slides. So today's session will focus on expanding COVID-19 testing to reopen economies, a panel discussion on testing at schools, borders, and workplaces. This is an issue that has become very important. It has become very critical as many countries over the world are experiencing second waves of COVID-19. And this has led to countries going back to stringent lockdown measures. And so countries are grappling on how to reopen economies, and if so, how is testing going to be conducted in different settings? And vaccinations are also taking off in a number of countries. To help us discuss this subject, we have the privilege of hosting very distinguished speakers and panelists who are joining us today. We have Dr. Jay Varma, Senior Advisor for Public Health at the New York City Office of the Mayor. Many of us know him from his previous role as the Senior Advisor to Africa CDC. We also have Professor David Heyman. He's the medical epidemiologist and the professor of the infectious disease epidemiology at the London School of Hygiene and Tropical Medicine. Thank you so much for joining us. He has done a lot of work, even was part of the team that went to investigate the first Ebola outbreak in DRC. Also, we are privileged to have Dr. Alex Cook, who is an associate professor at the National University of Singapore, and he has done a lot of work around disease modeling and statistics. And finally, we are also happy to be having Carlos Eduardo Gouveia, who is the founding member and the president of ALADIV, that is the Latin American Alliance for the Development of In Vitro Diagnostics. So to help us and help me moderate this session today, we have a guest moderator, Renuka Gade. She's the senior advisor at the Clinton Health Access Initiative, and she's also the ASLM board member. So this conversation will be happening also even on Twitter. Please join our Twitter conversation at hashtag COV-AGRDT Africa and follow the conversations that will be happening there even during this session and even after this session. To help us get started on our session today, I would like to welcome Dr. John Kengason. He doesn't need any introduction. All of us know him very well. He's the director of the Africa Centers for Disease Control and Prevention at Africa CDC. So Dr. John Kengason, over to you to give us your opening remarks.
Thank you, Lovo, for your very kind invitation to contribute to this very important session. And it's good to see many friends and colleagues looking strong at the start of the year. Let me say that, take this opportunity to wish all of us a happy new year. I think we are in February, but I think New Year wishes are still in order for those who have not had the opportunity to greet each other. It's good to see all of you, I mean the panelists, all old friends and colleagues. So let me maybe sequence my remarks in two dimensions. First is really what we did in October last year. In October, in anticipation of the October 2020, in anticipation of the fact that the continent was going to start easing down the lockdowns we launched what we called the Africa Against COVID-19, which was an initiative underpinned by the need to save lives, save economies, and save schools. And I must say that it was a very high-level program or initiative that brought together the WHO, as well as ministers of transport, ministers of health, to agree that we needed to coordinate and harmonize our approach for testing to address those three dimensions, i.e. saving lives, saving economies, and schools. Things have evolved since then, and we are now in the phase of expanding antigen tests. And if you put that in the context of where we were last year, exactly 1 year ago, as a continent that was challenged with testing, I mean, you can actually look back and with great admiration that the partnership that we all developed jointly with all of you, it actually led to what I call a revolution in testing when we launched the partnership to accelerate COVID testing in the abbreviation PAC. So I think we would also at that time remain hopeful that with new tests, what I call the second generation test, including of course the antigen test, that things will continue to improve. So therefore, I think of three things that I wanted to address very quickly. One is how do we continue to adjust testing and adapt testing in the context of our second wave that we are seeing on the continent, which all speaks to the very important need to address our economies. Second is the testing for to facilitate the rollout of the Continental Free Trade Agreement. For those who are following the African politics and development, you all are aware that we now have the free trade area where over 1.2 billion people can trade freely and move freely across the continent. That again is all dependent on how quickly we test and begin to address the issues related to the control of COVID-19. And lastly, testing for schools. When we launched that initiative, a key component, and we worked very closely with UNICEF, was what do we do to address testing at schools and improve uptake, and use that as a control measure, recognizing that it was very difficult for us to continue to rely on technology for homeschooling on the continent. So many students and people will not be able to access technology from home. So you really need to adapt testing in the school context there. So I'm very pleased today that this coalition that I would like to believe is share that same vision. And we are in the process of developing the right partnerships to continue to advance testing that will address both our travel needs, our economy needs, as well as the school needs there. So on that note, I think count on Africa CDC to continue to be a strong partner to work with the ASLM and all of you on this call, Child, and all the partners that I see here to advance and move that agenda, especially in the context of a very aggressive second wave of COVID-19 that we are seeing on the continent. Thank you, Nobu, for inviting me to be part of this dialogue.
Thank you so much, John, even for those remarks. You raised three most important issues there: the need to adjust testing in this second wave, and also the need for testing to support free trade that should be happening across the continent. And lastly, the issue of testing for schools. I believe these are the issues that our panelists today will be addressing in detail. So thank you so much, John, for making time. I know you're a busy person. If you are available, please stay with us. But if your time does not allow, please feel free at any point in time to just drop off. At this point, I would like to welcome Renuka Kakade, who will be moderating the panel discussion. Over to you, Renuka.
Thank you, Ndlovu, and it is a real pleasure and privilege to moderate an ASLM panel. ASLM has been doing so much to amplify the need for action in the context of COVID-19, and it is a privilege to also be, hearing Dr. John Nikangasang, who has been a leader on the continent and globally so for the work that he does in strengthening responses for pandemics, labs, and a pure privilege. But I'm very excited here to be with a group of panelists who really need no introduction, who will talk to us about now we have science data better than ever before, but what can we do to still control the pandemic, as you say, the second wave, more virulent strains. We hear the rhetoric, vaccine versus variant, the race. We hear reopening of schools, then shutting down of schools. We hear discussions on what should happen for travel, airport testing, land border testing, and what should you be doing at workplaces. So we kind of assembled a group of global experts who can talk to us about what's happening in their settings with evidence. Then we will follow up with an Africa-specific panel in the next 10 days, where the African leaders will talk about their response. So with that as context, I think Chai and several other partners of the Diagnostics Consortium, including FIND and other agencies, are engaging with WHO to look at this landscape. There is evidence there now that there is great performance with rapid antigen tests. There is modeling to state that the use of a combination of antigen and PCR can still be very cost effective. The use of repeated tests is possible because of the access to rapid tests, low cost of rapid tests, the timeliness of response. But let's just take a pause. That session is not what the context is today, but just let's remind ourselves about that context and say, now that we have these tools, what would be the right approach, and how and when do we use them? So with that as context, my first question will go to Dr. Jay Verma, who again has been in several roles, and I'm not sure that the resume, the profile, the introduction to Jay was appropriate. So Jay, I'm going to ask you to really put you on the spot here to describe your various roles that you've been engaged with. And I know that there is a US CDC, I know that there is Africa CDC, and I know that you're right now in the mayor's office in New York. And please, if you don't mind, introduce yourself before you start. But my questions for you really are, you've been leading the country's largest school testing program, I believe. What's the evidence and data that you're finding in schools? Testing students, testing teachers. Give us an update, and how would you look at the use of tests in the context of reopening schools? Over to you, Jay.
Great, thank you, Renuka, and thank you everybody for taking time today for this important topic. Yeah, just for brief background, I think many of you I've actually worked with in the past in many different settings. Up until April, I was actually based in Ethiopia with John and had been at Africa CDC since its launch in early 2017, serving as a senior advisor to John to help work on our strategy and programs. And sort of suddenly, because of COVID, for sort of personal and patriotic reasons, had gotten a request to come back to New York, where I had worked for many years, and from 2011 to 2007. Came back in April at the height of the epidemic at a request from the mayor to help guide the city's coronavirus response. And so I've been here since April of 2020. So I have a lot of experience, as all of you can imagine, in both the world and now in New York as well. And really, I think one of the most important things for us to all keep in mind is that the sort of traditional relationship between what the sort of well-resourced European and North American countries can do has really, I think, as we all have seen, the most important component for all of these responses is strong political commitment and social cohesion. And there was a tremendous amount to be learned here in the United States from the experience in Africa and other places around the world. So I have been privileged to have had the opportunity to learn from so many of my colleagues in Africa before this and help bring some of that learning actually here to the United States. I think it's an important lesson for all of us. And as we get to the topic of testing, I'm going to describe for you sort of the lessons that we've learned in New York. And I think that, again, we have to keep in mind sort of the resource issues that are involved. There is an ability to sort of spend money in ways that you can't necessarily spend in other places, but a lot of that actually starts with political commitment. It's not so much the budget itself, but it's the commitment. And I think what's been important here in New York, even though I'm going to describe a program that is extraordinarily, I think, extravagant, I think, in its spending, has taught us some really critical lessons. And it only started because there was, in fact, political commitment. So that's kind of my opening sort of introduction. Now let's get to the topic at hand. So what do we know about testing? I would start by actually sort of flipping this a little bit and emphasizing that testing is actually not the most defense in schools. Just for some background, the New York City school system has about 1.1 million children in it and over 1,600 schools. So it is the largest school system in the United States. Currently, at this exact moment, the only schools that are open are kindergarten through 5th grade. And that involves about 150,000 students covering over 800 schools. And there are also about 50,000 staff that work in those schools. So that's not just teachers, but that's administrative staff, custodial staff, et cetera. So it's still a fairly large population. And what we've learned is that the most important lines of defense are the ones that we already know and emphasize in the community setting. Those are universal adherence to masks, physical distancing as much as possible, improvements in ventilation, and really the investigation of cases associated with schools. So that is the basics: case investigation, contact elicitation, contact tracing, and quarantine and isolation. And I think layered on top of that, of course, is as many efforts as possible to get here with basic symptom screening at home so that people who are sick, whether they are staff or students, don't come to schools. So those are really the fundamental elements. And what we had to do in New York City to open our school system in September, and when it was open in September, we had all of our schools were open, in fact. We had to decompress them. And so there had to be the adoption of a hybrid testing school model where kids were in school 2 or 3 days a week physically in person, and the other days were online. And that was the only way to reduce density in the classrooms. But all of the other components are really just policy measures and practice measures: mask adherence, distancing. So what we learned then by testing was that we first had to approach this question from the perspective of what is our purpose? Like any public health intervention, of course, you have to decide, why are you doing it? And I sort of break it down into sort of 3 big areas, which I think all of us can agree to. You know, testing can be used for surveillance, it can be used for disease control, and it can be used for diagnosis. So by surveillance, I'm really referring to, you know, doing testing on a continuous basis, you're effectively doing point prevalence surveys. You're taking a snapshot in time of what the prevalence of infection is in your schools. And really, I think the primary metric you want to see is that the prevalence in the schools is no higher than what you would expect from the community. Now, one of the challenges, people often compare those point prevalence estimates in schools to test positivity in clinical settings. So what is the overall test positivity? But of course, we know that will be an unfair comparison because test positivity in the community is going to reflect a lot of sick people going to get tested. So you have to look at estimates of what prevalence might be in your community. And so for that purpose in New York, we relied on modeling to try to get a sense of, if you could take a random sample of the population, what percentage would be positive? And so how does that compare to the test positivity in your school? So that's testing for surveillance. The second is testing for disease control. And by this, I mean, you're really using testing as a way to identify who you need to isolate, who you need to quarantine, and whether or not there may be outbreaks. So it involves a continuous process of testing because you're actually trying to catch disease early and then respond to it quickly, including among those who are symptomatic and asymptomatic. Now, when we do testing in New York, which I'll again describe the details in just a moment, we're actually doing it for this purpose also, because we have had to add on basically a new component of our contact tracing program that is only dedicated to the schools. It is something that we call our situation room, which includes a representative of the educational officials, city officials that actually are responsible for building management and environmental issues, and then of course the health teams that work on contact tracing. So it is an integrated control room to manage contact tracing and disease control specifically for the schools. And then the third purpose of testing, of course, is for diagnosis. And this, of course, is the one that we all know. You could set up a testing program in schools that is exclusively focused on trying to get rapid point of care testing for anybody who becomes symptomatic during the day, whether as a student or a staff. And this, of course, requires you to have some clinical staff on site at all times because people could become symptomatic at any time. So that is the overview, I think, of the basic purposes, which is surveillance, disease control, and diagnosis. So what are we actually doing in New York? Because I've sort of talked around this a little bit. So what we ended up having to do is to decide that, in fact, the main way that we wanted to be able to do testing was primarily for the purposes of surveillance. And that was because the ability to do testing on a basis that would actually be necessary, such as repeated testing multiple times a week in so many different schools, in 1,600 schools, was logistically not possible. It wasn't even so much an issue of budget, because again, here we had a strong commitment from the mayor that we absolutely had to try to get the schools open if we could do it safely. And it was my job to basically say, yes, we can do it safely, and these are all the things we can do. But we decided that the primary purpose of testing at the beginning was going to be for surveillance, but that we would also be using those test results for disease control. So that is why I described that we also set up a unified command center to manage these cases. So what we decided to do was to basically do testing, and now it has become every week. It originally started as once a month, to go into schools and to sample 10 to 20% of the in-person population. So that means you essentially create a roster of who is there on that day, students, staff, of any sort, and then you sample anywhere from 10 to 20% of that population. For schools that were very large, that had over 1,000 people in them, we only sampled 10% of the population. And for schools that were smaller, that had fewer than, say, 500 people, we did a larger sample, 20%. And that was so that we could get some type of statistical validity. And we used the data to, like I said, to compare it to what was going on in the community based on modeling estimates. And then, of course, any positive results, we had to guarantee that results were reported quickly. So these were all PCR-based tests, and we had to set up a special laboratory program where we could get results back. The majority of results, 85% of them, come back within 24 hours, and then the remainder all come back within 48 hours. And then if there are any positive cases, we actually require those students to be, isolated, and then we actually treat the entire classroom as close contacts, even if there was, even if the kids were physically separated from each other. And that was a decision that we made because we just had to make the safest possible approach. And so what we have done in terms of our results is now, since October, we've actually done 400,000 PCR tests, 400,000 only for testing in this school's program. It averages about 5,000 tests that are done per day. And what we have found overall is that the test positivity, whether in children or in adults who are working in the schools, continues to be at the level or below the level of what we'd expect based on modeling estimates of what we would find in the. Right now, because we are in the middle of our second wave, our test positivity in the community, just for reference, is about 8%. And that represents actually about 100,000 PCR tests done per day in the city of New York. So again, 100,000 tests per day. Our test positivity right now is about 8%. So that's for the entire city. But in the schools right now, our test positivity is around, I just got the data from today, it's around 0.4%. And our modeled estimate of community test positivity, if you take a random prevalence of the population, is somewhere around the level of around 1 to 1.2%. So again, we continue to see test positivity that is lower than what we'd expect from the community.
So a lot of information in
because that's
here.
a lot of information. Renuka,
yeah.
yes, some questions.
Using testing for surveillance, for disease control, for contact tracing, using testing every week, difference in the community level versus schools. It's a lot of information, and I'm sure everyone's noting that with interest. You've referred to PCR testing, New York, rich place, budget's not an issue, is what you said. And with the onset of newer rapid tests with very powerful data, especially when you're looking at frequent testing, do you see that as a tool that, particularly for resources that are not as well resourced, or even the advantages of knowing your result immediately? How do you see that play out? But before you answer that, in the context of let's say Africa, temperate climate, different climatic conditions than snowy day in New York today. And is it the same model, or just what are your thoughts? Again, there are experts on the continent who are looking at this, but would love to get your views on this.
Yeah, no, thank you very much. I think to be very clear, I do not think this model is replicable in too many places, even in the United States, because most school systems in the United States, first of all, don't have the political commitment to do all of this work, because it requires a tremendous amount of investment, and nor do they necessarily have the money, even if they could actually had that commitment. So what I think is absolutely critical in terms of applying to less well-resourced places, and that includes across the world, not just in Africa, is number one, is to really focus on the things that aren't related to testing that you have control over. So that includes mask adherence across all age levels. And I know there's some debate about this, but we ourselves have felt strongly that, you know, our school system includes kids for basically 5 and up. For the lower age groups, there is mask recommendations for 2 to 5, but it's not, you know, as well adhered to. But from 5 and up, I think there's very strong adherence in the schools. So universal mask adherence. The second is in temperate climates to really maximize airflow. And of course, we know this because of you know, we've for many years, many of you have worked in TB control in healthcare facilities, and we know that if you can maximize airflow, you can reduce airborne transmission of disease. So the same has to be true in school. So that's number 2, maximizing airflow. And then the third is trying as much as possible, as much as your systems will allow to decompress the classrooms. I think trying to fix physical distance between people is going to be really essential. But then when it comes to testing, I'll explain to you one of the reasons we haven't used antigen testing. We actually find operationally, it is actually much more challenging to do. If I wanted to do this exact same program where I go into a school and I test 100 kids out of 500 or 100 people out of 500 that are there, the school day would never start. Like I literally need to do those tests and I need to wait 10, 20 minutes for results for everybody. It actually operationally is much faster for our teams to go in to do, and we do anterior and area swabs, to do an anterior and area swab on a huge number of people and then move on to the next school. So we've actually, and then there's also the issues of interpretation. You need to have staff that can interpret correctly on site. And then there is the issue that we were concerned about at the beginning about validation in asymptomatic children, because there was very little data about accuracy. And we're concerned about making high consequence decisions when you have concerns about false positives. Now, flip that to the lower income setting where again, the cost of doing PCR testing is going to be extraordinarily high. I do think that you could set up a system to essentially use antigen testing for I think the primary purpose in my mind really should be for diagnosis, because I think that the fundamental reality is that most parents are going to need to send their children to school. They really have no other options otherwise. And so I think they should go to school. And so the reality is that they're going to be kids and adults that are going to show up with illness. So having it there on site for diagnostic testing is going to be critical. And I think layering on top of it, using, you know, syndromic methods, looking at symptomatic illness as a way to track for potentially for outbreaks. So using it primarily for disease control and for diagnosis. Surveillance, I think, is possible, but I do think it is incredibly expensive and costly. And so I think places need to consider how important that is. If it's possible, if you have the resources, absolutely. It provides another way to, we have found it to be incredibly useful because it reassures parents and staff. There was a tremendous amount of distrust because so many parents, so many teachers got sick during the first wave. So we found this to be very useful from that perspective.
Excellent points, Jay. So reassure parents, teachers, build the trust, reopen schools, focus on what works in your setting and operationalize it effectively, because it's easier said than done when you're looking at testing on a weekly basis. So all those points are fabulous. And I have to say, learning loss is a real issue. We've seen experts talk about it. The fact that you see a decreased enrollment in high school kids applying for colleges in the United States, I think I read somewhere it's about 20%. These are very serious issues, and for the sake of our children, schools must reopen. I'm going to paraphrase what you said to me when we were talking about this. Schools should be no different than healthcare institutions. They are essential services, and we're talking about a generation ahead of us, and learning loss is simply not acceptable. So your points today are very well made, and I think it will spark a greater discussion among the experts as many countries are looking at testing models. So really appreciate your comments. Stay tuned because there will be questions that will come your way, but I'm going to move to Professor David Heyman as our next panelist. David, your reputation in the space of addressing any outbreak and any pandemic is, undisputed. You are with the London School of Hygiene and Tropical Medicine, but very involved with and lead and co-chair many discussions with the WHO, whether that's been on SARS or Ebola or now the COVID-19. So the question to you, David, is tell us what's happening in the latest with the vaccination. I recall reading Dr. Nikangasang's writing that by the time the vaccine reaches all countries in Africa, it's not an on and off switch. It's going to take a few years. What is the latest that you're reading or that you know about vaccines that you can share, timelines, and give us an update first on that landscape? And I'll ask you a follow-up question, David.
Okay, thanks very much. I'm going to share my screen here because I tried to be concise in what I wanted to say. So thank you very much, Renuka, for having invited me. I think that most of us believe that SARS coronavirus 2 is endemic and will continue to be with us for quite a while. So the strategies early on of eliminating the virus were strategies that were an attempt. But I think we have to be realists today and say, at least for a while, this virus will be with us. But the good news is, as you said, Renuka, that there are a variety of vaccines, therapeutics, and also diagnostic tests to help us learn how to live and to help us live better with SARS coronavirus 2. And all of these different interventions now have a place moving forward. There's been a lot, though, of misunderstanding, especially about vaccines, about herd immunity, and about the need to get more equitable distribution of vaccines to the people who need them. And at the same time, diagnostic tests have been quite undervalued, especially the new lateral flow and point of care diagnostics. So as you asked, what I'll do is just start with vaccines. And as I said, I put these on a slide so I could be more concise in what I say. And really, as we all know, vaccines have been tested against an endpoint of serious illness and mortality. And the vaccines that we now have are doing that. And what will happen, I believe, and I believe most people believe, is that as our politicians see that the burden on hospitals has decreased, that mortality has decreased, they will be able to approach the pandemic and the endemicity of this infection in a more public health epidemiological way, rather than in blunt lockdowns which suppress transmission. So we have a vaccine, we know that it prevents serious illness and mortality. What do we know about its impact on transmission? Well, we assume that because it might decrease viral load in those people who are infected, but do develop less serious illness, it could decrease transmission because of that. If indeed the vaccine is only decreasing the seriousness of an infection which presents itself in a human. We don't know anything much yet about nasal carriage. A couple of the studies that were done showed that there might be fewer people with high levels of nasal carriage as a result of vaccination. But remember, carriage of viruses occurs in many different vaccines. Polio vaccine, for example. You can be immune to polio and still carry polio virus in your gut. And with bacterial vaccines, such as the first generation of meningitis vaccine, nasal carriage continued, even though you were protected against meningitis. And finally, we all are waiting to see a herd immunity effect. We hope that vaccines will add to that. But again, we just don't know whether these vaccines are decreasing transmission in the community and whether they can contribute to herd immunity. That's also complicated because we don't know the duration of immunity. Will there need to be revaccination? If so, how often? And the variant escape of vaccines is very concerning right now because we are seeing in South Africa that the current mutant strain that's circulating there, and probably in many other countries, but that's circulating there, has shown that there is a decrease in neutralizing antibody to that variant in the laboratory in people who were previously infected with a different variant, or presumably with a different variant. So we're seeing that maybe, in fact, if antibody is the correlate of immunity, that we are seeing a little bit of a decreased impact of previous infection. And then again, can we use vaccines to make our workplace safer and travel safer? Can we use an immunity or a vaccination passport? Well, certainly these are very important for personal protection, and entering a workplace with a vaccine will ensure that you're protected personally. That doesn't necessarily mean that you're protecting the others, and that's why mask wearing and physical distancing must continue. So just a short summary of vaccines, Renuka. The fact that vaccines we know today prevent serious illness and mortality, and there's a great inequality in their distribution around the world. And we really have to be working with the COVAX facility to make sure that happens.
Well,
The next was, oh, go ahead, Renuka. Yeah,
no, I was
sorry.
going to say, can't stress that enough in terms of what you just said. It's rolling out, it's working, but it's too soon to conclude anything, right? What's the durability of the vaccine? How long will that effect last? Will there need to be a revaccination? I mean, so there are more questions than answers. So just to assume that we have a vaccine and kind of be relaxed is not the position you're saying. You're saying you should still take precaution, because you may be protecting yourself, but you still could be infectious in that context. And that's, I think, very important for people to kind of register. And I'm very intrigued by your vaccination passport kind of approach. So my question to you is, sometimes we hear this rhetoric and discussion, David, we have the vaccine coming, so should we then defocus on diagnostics and testing? And I think you started your opening comments to say how important it is to be looking at diagnostics in this space. And oftentimes diagnostics is an afterthought. And so you're saying no, but can you say that in the context of vaccine? Because program budgets are limited. People are excited about vaccination. Everyone wants to reopen and are waiting. And what then in that context, and how should one look at testing? Is it necessary, or can we just assume let's wait for the vaccine? I'm being a little provocative and controversial here, but I want to hear that from your end, David.
Well, what's really been interesting to me is to see how the Africa CDC, how the Institute Pasteur in Dakar, how various area activities in Latin America and Peru, for example, and others are trying to lead the way in showing that lateral flow diagnostics and antigen detection does have a place in the areas where we're using PCR in industrialized countries and where it's not available in developing countries. So I think that's a positive, that there are countries with lower resources that are trying to see what maximum value they can squeeze out of antigen detection tests. And they're doing that to a certain extent through various testing protocols, making sure that they're, what's more important? Have somebody come in 3 days after onset of illness and wait 2 more days for a rapid PCR or for a PCR, or to do a lateral flow antigen or even an antibody test to see whether or not you might be able to diagnose them a little bit earlier and get them into patient management and isolated. So that's, I think, the good news is that Africa CDC, groups in Latin America, Institute Pasteur and others are really working on better algorithms for diagnostic testing, understanding that PCR is the gold standard, but is not yet available. I don't know if that answers your question, Renuka, or not.
Yeah, that's good. Thank you. And I think we all agree that PCR is a gold standard and must be used for confirmation that guidelines that authorities have issued. And at the same time, how do you rapidly test and scale for routine testing, frequent testing, where you can use the rapid antigen test? I think it's a good point. So what in the context of vaccination then can you say is the role of testing? David, is there any other information that?
Okay, well, I actually, as you know, a little bit of a think through this on diagnostic testing during the COVID-19 pandemic. And many people say, well, now that we have a vaccine, it's all over, we're safe. But we really aren't safe, and we need to approach this through an epidemiological methodology. And so, of course, the first, and Jay said this earlier, is surveillance. And in this case, it's surveillance of influenza-like illness or surveillance of severe acute respiratory infections. And what we need to do is to do that surveillance in order to rapidly detect outbreaks, in order to rapidly diagnose patients and get them managed properly. In order to identify variants, we need to be using more specific genetic tests and maybe some nanopore technologies to really identify, to do the genetic sequencing in order that we can see where the variants are. And I know the Africa CDC, for example, is working to set up some nanopore sequencing in various sites around Africa. And finally, vaccine efficacy. It may be that we need to use some of these serological studies to estimate vaccination efficacy if we understand the correlates of protection moving forward. So there's a lot of need in ILI surveillance, especially maybe ILI surveillance in health workers who are the most exposed and likely to be the people who are vaccinated early on in countries, a perfect sentinel population in which to understand much through the surveillance systems. There's also the influenza system, which could be used if some sequencing can be hooked onto that. Finally, in patient management, Jay said again, we need to have good rapid diagnosis so that patients can be not only managed in a hospital, but discharged when they're no longer infective and sent out back into the community. We're going to need to do contact tracing, especially in areas where the outbreaks occur. This doesn't occur in a wave just entirely across a country. We all know that. It comes in and stops off in outbreaks, and then it spreads into communities. So we have a chance to stop these outbreaks if we strategically do contact tracing and test people that develop signs and symptoms. So if they're positive, if they're sick with COVID-19, they can be moved into a more secure isolation facility where they can be managed. We need to understand eventually immunity profiles in communities so we can better target our outbreaks, whether a community means a physical community or a group of workers or a group of young people congregating at the same place. We need to understand. And that's why antibody studies will be important going forward. We need possibly to figure out how we can get international travel back on track, as well as workers back into their places in a safe environment, remembering that vaccination, at this point in time, we know that vaccination will protect individuals. We don't know whether it will protect others on the airplane from someone who might be transmitting, who's vaccinated, and we don't know anything about the worker space. So we have to continue with our good epidemiological interventions, including physical distancing and mask wearing.
I think finally, perfect. Yeah, go ahead.
Yeah. I was just going to say one more, Renuka, is that we may need eventually to understand the correlates of immunity in order to understand when we can use an immunity passport or when we would need to give a booster dose. And with some of the newer vaccines, with the mRNA vaccines, it may be that you can detect an immune response to them as opposed to immune response from an entire virus. So all of these things will come out, and fortunately, Renuka, there is good post-vaccination surveillance in countries where vaccination is going on, and we'll soon have answers to many of these questions. Sorry, yeah. I interrupted you.
No, thank you. No, I was saying something that you said triggered my instant reaction to say, even if you have vaccines, you're saying you still need to be careful in different use settings. You mentioned travel, even though you will have a vaccination passport, to kind of understand the durability and the infectiousness of the person who's got the vaccine. I really liked your pointer to say healthcare workers who are being tested and vaccinated should be someone whom you should follow and look at the impact, so on to say. But to me, the takeaway is the need to be vigilant in different use cases doesn't go away just because you're looking at vaccine, not yet at least. And that leads us naturally to the next speaker then, Alex, who's been talking about use case travel, airlines specifically. So very quickly, Alex, what can you tell us about your work that you're doing, your modeling work, but what is happening in Singapore where you're based? Are they testing everyone at airports? Is that feasible, practical? What are they finding? But what is your modeling suggesting? If you could rapidly take us through those slides, that would be great.
Okay, I'll be as quick as I can then. So I'll start by talking a little bit about Singapore's epidemics. I think it shows quite clearly that testing at the border works. So Singapore's had a fairly good epidemic so far. We have one black mark against us, which is out of control spread within our foreign worker population. But I'm going to take that out because that's far too large a question for today's topic. If you look at the rest of the population, then actually we've had very few infections for almost pretty much the whole of the year since we had our first importation. I've separated them out by the imported cases from those which were locally spread. And I think it shows quite clearly that in the early period, especially, importation leads to local spread. I'm going to highlight a few different time eras from within the epidemic. Fairly early on, we closed the border to Hubei and then subsequently to the rest of China. But we were too slow to close the border to other parts of the world. In particular, around about March, we had a huge inflow of returning Singaporeans fleeing from Europe and America, trying to get out before the storm hit. And we allowed them to quarantine at home. And that is what led to the large wave just before we went into lockdown, right? So if we had not made that mistake, then we may have not had to go into lockdown. After that period, we went to a time window where we had no cross-border travel at all. So the land borders to Malaysia were closed by Malaysia. And also there were no imported cases because we didn't allow any travelers into the country. But from August onwards, or July onwards, we have been allowing some degree of travel into the country. And you can see that the vast majority of our cases are actually imported. They're not locally acquired. So since August, we've had about 10-fold more infections at the border than we have had within the community. Many of the community cases are actually linked to the border. So people working at the airport, for example, who may be infected from the passengers there. Okay. So how have we affected? Quite strong control within that last 6 months or so. So the default policy, which most countries most passengers from most countries would adhere to, is that everyone gets tested at the border. They all get 14 days of quarantine in a hotel, and they'll get an exit test before they're allowed out. The exit test will be a couple of days before the end of their quarantine period. There's some exceptions. Very low risk countries like China, for example, we can waive them through after the results of the first test are through. But for most countries, that would be the case. UK, I think 21 days because of the dangerous variant. South Africa, probably too. Now, I want to highlight just one important policy difference that Singapore has, which I think is one of the other ingredients why we've been able to control the outbreak so well. And that is that all of our infections are isolated in a healthcare facility from the very beginning of the outbreak. We have not allowed any self-isolation or people isolating at home, right? So they must be strictly isolated. Of course, it sounds a bit rash at first. You mean you put people in hospital even if you've got mild symptoms, but of course it's how you prevent them from infecting their households. When we've looked at some household studies, we compare how many secondary infections you have in Singapore households versus how many in American households. It's about a third less in Singapore, and I think that's a result of that policy. Okay, so that gives you kind of a sense of how we have been able to control things so well so far. But what we're now trying to look at is how we can reopen safely. So from a point of safety, how we can start to reopen and still remain safe. And so the way that we're doing this is to think about, can we relax that 14 days of quarantine, make it shorter so it becomes more bearable for international travelers. So the way we've been doing that is through modeling. We've developed, together with Becton Dickinson, a company that makes the tests, antigen PCR tests, we've been developing a modeling framework which allows us to simulate what would happen in silica if we have a large number of imported cases, and we push them through various different combinations of testing and quarantine and more testing. Accounting for a bunch of stuff that we know about epidemiology and about sensitivity of the tests. We're comparing different test types, PCR and antigen. Obviously, antigen is not as good as PCR, but as you'll see, it doesn't make much difference in the end. So I'm just we have literally done hundreds of scenarios, because every time I speak to the government in Singapore, there's always a new dozen scenarios that they want us to look at. So I'm showing you a highlight of just some of the hundreds that we've looked at so far. So what I'll show you here is where we've got PCR testing on arrival, PCR testing on exit from quarantine, and then different durations of the quarantine, 14 days being, as I said, the standard for most people. So we can calculate for people who were infected in up to 2 weeks prior to flying, that even 14 days of travel is not 100% effective. It will only filter out about 98% of the infections. There'll still be some left over who get through because they have a very long incubation period and the test's negative, even though they may already be infectious towards the end. Now, those are the percentages, but what is that? How would that kind of work out in practice? So we're considering, as Singapore has done, it's stratified according to risk of the source country. So we consider different source country prevalencies and then look to see how many infected travelers would attempt to come in given that prevalence and how many of them would be missed and would therefore lead to community transmission. So red countries would be places like the US or UK, green would be places like Thailand or China. And so if you have those numbers of infected passengers along the second row there, then that would lead to this many missed infections getting through to the community. So if you have a risk budget, which is actually how Singapore government is operating how many flights are allowed in, a risk budget for how many infections they are willing to permit, then you can decide for different source countries actually what regime you would want to have. So even though 3 days quarantine will still miss a substantial fraction of the infections, that might be acceptable for a low risk source country. That effectively is what we're doing for China. This last point I want to raise is that we've compared the effect of PCR and antigen here. Antigen test, as we know, when you saw the chart previously, has got a lower sensitivity. The sensitivity drops off quicker, in particular for older infections. But when it's in combination with quarantine and repeat testing, then actually the percentages don't change by much. I changed slides there. I don't know if you saw it because the percentages don't change much, right? So when we switch from PCR to antigen, if it is part of a broader set of measures, actually there's very little difference. So my view, and it's not because I'm paid by BD, my view is that you would prefer whichever fits best with the framework for control. So for example, if everyone is going to go into quarantine anyway, there's no harm doing PCR at the airport. But if you are wanting to get people out of quarantine, you want to avoid quarantine for the very lowest risk countries, then you could do antigen at the airport because it would be effectively the same.
Thank you, Alex. And a lot of good points that you made here. You know, just because a country, community is virus free, it doesn't mean the virus doesn't cross borders, right? And that's the example that you shared in arguably a small but well-resourced country like Singapore. And it's really interesting to see the various modeling applications. Risk budget is something, a new term that now is sticking in my mind, and on how countries should look at reopening borders. The role of PCR and antigen and the use case will vary depending on the policy guidelines, the country specific action, as well as the source country that's coming in. So very interesting. And I thank you for sharing a very detailed country example, even if it is in a high income country. We'll get to the issue of will this work in a land border testing scenario, particularly in low middle income countries. But I'm going to hold that question and pose it to our respondent at a particular point as we wrap up this panel, because I think there's a lot of data here that can be used as we look at low middle income countries. So thanks for that. My next speaker is going to be Carlos from Brazil, and we wanted to give a perspective about what's happening on that continent. Carlos, we often hear how Brazil's public health program, I think, was kind of off to probably a late start in terms of testing. And at the same time, we hear there is a very active testing program happening in the private sector segments in Brazil with reopening workplaces. So contrast that for us, take us through very quickly, because we do have to have a couple of questions reserved at the end, Carlos. So what's happening in Brazil? Give us your viewpoints here.
Excellent. Thanks a lot, Renuka, for the invitation. It's really with great pleasure that I'm here today speaking to you and sharing a little bit of the Brazilian experience. As you said, we had, let's say, a late start in some aspects, and we had also some problems with the Ministry of Health. Several ministers succeeded each other, in a difference of policies, which of course didn't happen. As a consequence, we had over 9 million confirmed cases of COVID, and that's with a very low testing rate. And so far, over 221 people were declared dead because of COVID infection. That's really a very bad situation. And especially if we see the mortality rate, we see there's two big waves. So we are seeing now another series of deaths related to COVID, probably also related to the new variant that has been found here in the Amazon region. As you can see, the coastline of Brazil, where the population is suffering more and more. So we had a very big problem from the beginning. We had a very strict regulation from Anvisa, our regulator, and we didn't have access to many products in the beginning, and it would take a long time to register them. So our major focus was on 3 pillars: access, so to enable entrance and registration of products. And thanks to Anvisa, we had a fast track for that. Quality, the second pillar, which was how we could actually monitor in a post-market surveillance effort together with the regulators, but bringing the private experience also together. So we could give a feedback to the regulator, to the market for procurement reasons, but also to manufacturers in order to have them improving their process and next batches. And finally, last but not least, mass testing. For the quality purpose, we had a unique experience. We got the whole private sector, so the medical societies, clinical analysis and clinical pathology societies, the Lab Med Association, AbraMed, and the industry entity, CBDL, which is the IVD sector altogether. With the support of London School and IDC, we were able to get together over 13 labs, public and private, that were able to monitor over several of these products: antigen, antibody, PCR, ELISA, chemiluminescence, all the different technologies that were in the market. This meant over 15,000 samples of patients in Brazil that were used to give this performance rate: accuracy, predictive value, positive and negative predictive value, sensitivity and specificity for the products in the market. This program got so well that we were even invited to support Anvisa, the regulator, in post-market surveillance activities for several of the kits. But the main point today is exactly to talk about mass testing. We were counting on the Ministry of Health, as they said in the beginning, by March, April, that they were doing or going to do over 46 million tests, more or less half and half between PCR and rapid test antibody. The fact is that with so many changes and political discussions, unfortunately, the pandemic in Brazil got too political. We had no more than 11 million tests acquired by the Ministry of Health. Not everything was used, and even though we had to look for alternatives. However, it must be pointed out that the ministry is today considering to use large-scale antigen tests for some of the public programs. The fact is that we had a situation. Diagnostic tests could only be used in professional areas, like hospitals and labs. That's the law. So we're talking about 6,000 hospitals, 18,000 labs. Was that going to be enough for 121 million, 212 million inhabitants in the country? Of course not. So we had to look for alternatives. Next step was pharmacies and drugstores. We have over 88,000 in the whole country. So with Anvisa, again, it was possible to discuss a new regulation that allowed them to do rapid testing in their premises. Initially only antibody, now they're also doing antigen testing. And what about the role of companies? Companies could play a lot in this pandemic fight. And indeed, it was already possible if they would be served and had a contract with a clinical analysis lab. They could do PCR and antigen antibody testing in their employees, but they would need a professional support. The fact is that these two extra steps started to happen, not only for information about the individual status, but mainly to support the return to work. Antigen, a curiosity, it started in Brazil in November, and up to now they have grown so much that they represent over 40% of the total volume of rapid testing. In terms of return to work, we had to urgently promote a safety protocol to promote the testing in order to return to activities. So what could be done? It was the combination of testing. And this had to be planned and executed in accordance with protocols. Extra support came from pharmacies. As I said, they were able to reach this invisible patient where nobody would reach. So up to now, only 2.8 thousand pharmacists joined the program, but they had already over 2 million tests performed. Events, several commercials, different kinds of gatherings had started to happen, again, with the promotion and execution and deployment of antigen and antibody tests. Drive-thrus, not only in parking lots in different locations, but also in terminals, buses and metros, subways, with a very good solution to also reach this person. Activities, all the different kinds of activities, especially sport activities like soccer games, border control, and finally, companies. Companies started to do in all the different sectors. And what they had to actually implement was a prevention protocol, containment protocols, training the staff, adaptation of the structure because social distance is a must, it has to happen, and the test could happen as screening or eventually as confirmation. So nowadays, it has been moved from antibody test that was being used in the beginning to antigen testing, because that's very effective with a good correlation with PCR results. And it has been a very, very common thing for all these different kinds of activities. Some companies still do antibody and antigen, and antibody in order to check immunity, although we have several reservations, we have several comments about that, but it's also common. And antigen for those in order to check current status in terms of presence of virus and antigen. And PCR is using for all the confirmation. So basically what we have to consider is that we have to have diagnostic as part of the solution. And we need to have and count on the right test in the right patient, right place at the right time. This combination really can improve a lot case detection. And we know there is a role for everything. And that's what we have to know and consider, because diagnostic can indeed be the best tool for developing public health policy. And we hope to promote a quick return to a normal, if that's possible, phase of the economy. And I hope to see you soon checking this nature in Rio de Janeiro, personally, not virtually. That's it. Thank you, Renuka.
Thank you, Carlos, for leaving us with that vision that, you know, it'll be bright skies and beautiful sceneries and people can travel fearlessly. But I also think I'm fascinated by how you walked us through the play of politics and policies. You know, politics that can often come in the way of rapid action, which is what you alluded to when Brazil had a slow start because of the politics, and then the changing policies, bringing in pharmacies as test beds where you can actually test people. There was a policy. And I also think it's interesting how you're using every tool in the toolkit, and sometimes rightly, sometimes wrong, I guess. Started off with antibody testing, then reversed to using antigen and PCR, which is the gold standard as the referral. So it's really interesting to see the catch-up play by a large country, and hopefully that last slide of beautiful skies is something that we can all look forward to. But I see there's an active chat going on, and I see some of the panelists are responding to questions already, which is great. I encourage panelists, if you have a time to look at the chat simultaneously, to respond to the many questions that are coming our way. But I'd like to invite, as the first respondent, for me, this has been a fascinating panel just to hear so many viewpoints and so much of data that's backed by evidence. I'd like to invite Brooke Nichols, who is with the Boston University, but Brooke has a fascinating journey herself and lived in Johannesburg, very actively involved in looking at various modeling and strategies, particularly for border testing. But Brooke, what's listening into these experts, what's on your mind, and what would you want to share with us from the work that you've been doing in the context of LMICs?
Thanks so much, Renuka. Yeah, all of the presentations were really interesting, and it's trying to think about testing within all of these contexts. And then because I work primarily on modeling of scarce resources, when we look at rapid antigen tests or PCRs, we have to realize how scarce these resources are. So when I think about all of this, and from everyone's talk, how do we bring all of these different ways to use rapid antigen tests together? And when do we use what, and where do we prioritize tests? And from that perspective, that's how I got involved in border crossing algorithm development and trying to figure out, so very similar to Alex's presentation, which was very interesting. We thought about things in a very similar way, but in a very different context. So when I started doing the work on border crossings, we were really thinking about other parameters that might matter. So there's no obligatory quarantine in hospitals like there is in Singapore. If we think about border crossings, especially land border crossings, there has been a lot of deployment of rapid antigen tests to the borders, but that's created a lot of unexpected trouble, honestly, at borders by creating long queues and getting people to wait together and creating more of a high transmission probability. So kind of defeating the purpose of rapid antigen tests in the first place. So to sort of think about how and when should we be using rapid antigen tests at the borders? Should we be doing it for everyone? And what other factors could it depend on? And so something that we were looking at through a mathematical modeling perspective was how many imports into a country per day of imported cases per day can you allow that would not impact community transmission more than, let's say, a relative 1% over the course of a month. So we calculated that value for different levels of reproductive number, RT, to then figure out, depending on where you are in your epidemic. So for example, in South Africa, they were just heading right into the second wave. If you allow additional number of people, oh no, crying child. If you allow a different number of people crossing your border during a period of epidemic increase, it doesn't matter as much if a few additional people cross the border with infectious virus. So sort of the algorithm that you choose very much depends on where you currently are in the host country that is then receiving people that are crossing the border. So we then tried to sort of contextualize sort of what Alex was talking about, but then saying what proportion of people are arriving through air and will likely have a negative PCR to travel through air. And then sort of how much is the rest of those cases going to be coming across the borders? And then what proportion of people do we actually need to test, or do we need to test using rapid antigen to prevent additional community spread? And so sort of these different sort of things that we're pulling on at the same time. It's how many people are crossing the border, what's going on in the country itself, and what are the available resources? Because if border testing isn't going to make a big impact on community spread, given the circumstances, perhaps those resources could be better allocated to different parts of the country. So either school testing or workplace testing, or any of the other different mechanisms. And I would be really interested to see modeling work that really tries to integrate all of these in sort of one cohesive way, but be happy to talk more about that. Thanks.
Excellent. So I think this has been a great session. I want to kind of turn it back to Ndlovu, if you want to make any closing comments, or maybe have our panelists say, final word. But I think there's so many questions that are coming in. As I said, Ndlovu, do you want to point us to one or two questions that the panelists can take from this very rich discussion? And I know this is all recorded and it will be shared on on YouTube for a wider dissemination and digestion of the many details in here. But some key questions from the chat room. Ndlovu, any thoughts on that? Or let me open it up to the ASLM team.
Thanks a lot for this. I think given our time right now, we might not be able or in a position to really manage a few questions. I would probably give this time for the panelists to give their, 1 minute or half a minute.
Okay, that's great. So then let me go back and say, panelists, what's your parting shot? Give us a high-level closing comment. What's coming to your mind, just hearing each other and hearing the reactions on the chat. So let's start with, in the same order, perhaps. Jay, are you still with us?
Yeah, no, I'll just get back to my main message all the time, which is do not think of testing as your first line of defense in schools. Think of your first line of defense as all of the things that we know are important for community control, and just use testing in a targeted way for the purpose for the purpose you have and for the resources that you have available to you.
Fantastic. Thank you, Jay. David?
Yeah, thanks, Renuka. I think what I would say is that testing will continue to be extremely important, and we will depend on the global community together to figuring out which testing algorithms are best for each situation. And it's been shown that developing countries have a major role to play in this, lower middle income countries, and should continue to do that moving forward.
Fantastic. Alex?
Okay, so although Singapore has had quite a good epidemic, there are other countries in our region, in Asia and Southeast Asia, that have actually had better epidemics so far. These would be places like Cambodia, Vietnam, Laos, PDR, and Thailand. These are all lower income countries compared to Singapore. So it's not the case that you need to be rich in order to have a successfully managed epidemic. In particular, those 4 countries have all had pretty much the same border strategy as Singapore has just now. So testing and quarantine.
That's interesting, and thank you for adding color on the other countries that are not in the same economic league as Singapore, but still very relevant use case. So thank you for that, Alex. And Carlos.
Well, Renuka, I think right test, the right place, right person at the right time. The combination of different solutions and tools are the best to really achieve the best result as possible. And another thing is really the combination of efforts, civil society with government, with academy. That's a must in this fight.
Great. So we have had over 300 attendees on this very interesting panel. We have Brooke, a resource who's there for modeling on the continent as well, and a lot of work being done by the African leaders. I just can't thank you enough for this very interesting discussion on use case settings. It's the first of its type, and it won't be the last, because I think this will trigger a lot more discussion and activity on the continent and elsewhere. So a special thank you for the panelists. Special thank you to ASLM that brings us all together. And it's been a privilege just being part of this conversation. Back to you, Ndlovu, for any closing comments.
Thank you so much, Renuka. Let me take this opportunity to really appreciate the panelists that have made time to be with us today. Thank you so much, Jay. Thank you so much, David. Thank you so much, Alex and Carlos, really for taking time from your busy schedules to be with us. A very important issue to be addressed as we face the challenge of COVID-19. I really appreciate the time, and also I'd like to appreciate John Kenkerson, even for his time to come and provide his key opening remarks. And lastly, to you, Renuka, thank you so much for such a brilliant job that you have done, really moderating and taking us through this session with the very important discussions coming out of this. And I would like to thank everybody who has attended, very encouraging numbers that were here today. So thank you so much. We going to be having a series of these discussions, and we look forward to be having you again in this series of discussions. So thank you so much. Have a wonderful day. Our session has come to an end. Thank you. Bye-bye.